All right, used to be hypertension, but now diabetes has overtaken hypertension. So diabetes has now been the leading cause of the exact cause is acute tubular necrosis, meaning the because of the sluggish blood flow that results from uncontrolled hypertension, I mean diabetes, from constant hyperglycemia that leads to the thickening of the blood, sluggish blood flow to the fragile glomeruli and the tubular component of the nephron, they damage the nephrons over time. So we call that acute tubular necrosis. The, cle- the clinical feature of acute kidney injury is oliguria. However, there are some patients who do not manifest with oliguria, but it's a small portion. Maybe 10% of those who go into AKI don't present with oliguria, but most people do. About 9 out of 10 patients with AKI present with oliguria. Although it says here 50% are non-oliguric, it's actually less than that. But there's a good lining, you can say a silver lining there, because if the patient is non-oliguric, they tend to recover quicker than oliguric patients. Let's look at the causes now. So there are numbers on this figure representing the cause of the kidney injury, acute kidney injury. So we have pre-renal, intrarenal, and post-renal causes. Pre-renal means, as labeled here, they are causes that lead to a decreased blood flow to the kidney. So here you have your renal artery branching to the right and left kidney. So if there's any problem resulting in decreased blood flow to the kidneys, that can cause pre-renal. If there's any condition, let's say medications, for instance, toxic, nephrotoxic medications, or substances that like IV contrast dyes, that or toxins that enter the kidneys, that's called intrarenal cause. And then finally, 3 is already labeled outside, has nothing to do with blood flow, nothing to do with the parenchymal injury, but has something to do with obstruction of urine flow now. Are you with me so far?
Yeah.
So again, without looking at the list, what are possible causes that will lead to decreased blood flow to the kidneys, which we discussed last week?
Right-sided heart failure.
Both actually. So if the patient has heart failure in general, that will decrease cardiac output, correct?
Yeah.
Once you have decreased cardiac output, then that will lead to less perfusion to the kidneys. Because remember, once you have decreased cardiac output, the sympathetic nervous system is now automatically stimulated along with the renin-angiotensin aldosterone system, which will only shunt blood to the heart, the lungs, and the brain. So leaving less blood flow to all other organs. So in fact, it's not only the kidneys that will suffer, but the rest of the peripheral organs. What else besides heart failure? Let's say I cut Mr. Richard's carotids. He's bleeding. Can that lead to pre-renal kidney injury?
Yeah.
Or let's say Trinessa decides to have a um, major surgery, okay, to get rid of her waist, like to trim down her waist, to shape her body like a, what do you call that, an hourglass, okay,
Okay.
major surgery, and then she bled a lot during the surgery. Can that lead to pre-renal kidney injury?
Yes. Yes.
All right, so Trinessa, don't do that, okay? You're beautiful the way you are. Please reconsider that plan. How about if Miss Vivian has a stenosis of one or both renal arteries. So there's a stricture here. So there's a stenosis. This thing here has a narrowing. Can that lead to pre-renal kidney injury?
Yeah.
All right, so you get the picture.
So
Anything
any
that, go ahead, sir.
Oh, no, I was gonna say basically anything that like stops or slows down blood from going to the kidney
Yeah,
could
that's
cause
belongs
it.
under pre-renal. So we have a lot. So last week we did diabetes insipidus. So diabetes insipidus leads to dehydration, so that will lead to pre-renal kidney injury. Let's go now to intrarenal. So again, without looking at the list, what I already mentioned, IV contrast dyes. Um, I didn't specify what nephrotoxic medications though. So what are examples of nephrotoxic medications?
Aminoglycosides.
Very good. The mycins are very nephrotoxic. What else? What is that diabetic medication? The oral diabetic medication that we hold if the patient receives any IV contrast dye?
Metformin.
Metformin. Very good. So we have a lot of medications. We have list there. NSAIDs are also included, especially the parenteral form of NSAIDs. We also have what we talked about antibiotics. We talked about IV contrast dye and oral pills. Any other substances that can damage your kidneys? Heavy metals also, right? Or remember acute hemolytic reactions, blood transfusion reaction?
Oh yeah.
That can also damage the kidneys, inside the kidneys. What about
Professor,
infection? Yes, go ahead.
how the drug overdose?
I didn't hear that, sir.
I said, how about a drug overdose?
Yes, okay, yeah. Drug OD, yeah. Richard mentioned if somebody ODs on any drug, because that will overwhelm not only the liver but also the kidneys in elimination. So I was about to say the
That's a duck.
infections. So kidney infections. Let's say you have pyelonephritis, which is in a later module this semester. They're the earlier part of the chapter of chapter, what chapter is this? 62, which we will talk about later. So a complicated urinary tract infection. So it starts as a lower urinary tract infection, and then it was untreated. It travels its way up to the kidneys, causing pyelonephritis. Or you have childhood illnesses, for instance, like glomerulonephritis. Um, or if you have cancer, for instance, renal cancer. So these are conditions leading to damage to the kidney parenchyma itself, or the kidney
Professor
tissue.
Professor,
Yes.
could excess lick alcohol also cause it?
Eventually, yes, but it'll kill the liver first before the kidneys. But
Oh,
you'll learn that next semester as we talk about liver cirrhosis. But yes, there is something called hepatorenal syndrome, which results after the liver fails.
okay.
Liver fails first, and then it will affect the kidneys.
Okay.
Let's go now to post-renal. So what conditions could obstruct urine flow, causing it to back up into the kidneys? Because once the urine is produced by the kidneys, it's not supposed to go back in there. It's supposed to go out. So what conditions can block urine flow?
A kidney stone.
A kidney stone. So either the stone is inside the kidney, in the urethra, in the ureters or in the urethra. What about any prostate problems?
BPH.
Okay, so you can have prostate or bladder cancer or BPH, enlargement of the prostate, which will block your urethra here. What about strictures, because if strictures occur in the renal arteries, you can also have strictures in the ureters or in the urethra. I developed a stricture here when I was 9 years old. After I got my circumcision, I could not pee, and it was all day, and the treatment was even worse. I don't want to talk about it, but that was the most miserable time in my childhood.
Professor, I
So
have a question for you.
yes,
If you got a stricture in the renal artery and vein, wouldn't that be a pre-renal issue?
yes, because it affects blood flow to the kidneys. Very good,
Okay.
very good question. Now, in what was I gonna say? Okay, we'll talk about the rest again in the earlier part of chapter 62, late in a later module. All right. So here are the explanation of your pre-renal, intrarenal, and post-renal causes. Okay, so you read that on your own. Acute kidney injury has phases. Chronic kidney disease, though, has no phases. Chronic kidney disease has stages. There's a difference. Phases are periods. Stages are the severity of the illness. Does that make sense?
Yeah.
Okay, again, phases are periods that occur as the patient develops acute kidney injury. Stages, which applies to chronic kidney disease, indicates the severity of the damage to the kidneys. So let's begin with acute kidney injury phases. The initiating phase, I don't really um, necessarily recommend discussing or studying, because if you look at the description of what happens in the initiating phase, it happens to most of us. Meaning every day we are exposed to some sort of dehydration, because either you're so busy with classroom, you neglect to eat or drink anything. It occurs, but as long as we stop it, though, because here, as stated here, the condition is very reversible. And again, we expose ourselves to that. Let's say on busy weeks toward the finals week, that's when these things typically happen. You guys get so preoccupied with studying because you have to go to work. I mean, how many times have you had, for those who work in healthcare, that you had to have to hold your urine for the whole shift pretty much? Okay, because you have no time to eat lunch or go to the bathroom, right? We've had days like that. But we didn't end up with kidney injury, right? We were fine because we eventually stopped the whatever led to that event. So let's start with the oliguric phase, because this is now where the damage begins. So you had the initial stage, you exposed yourself to what we just discussed here. So we were exposed to either pre-renal causes, intrarenal, or post-renal conditions. Now, so we went through the initial stage, but then we didn't do anything. There was no intervention. We did not stop the triggering events or the insulting, injuring events, let's say. Now we entered the oliguric phase. Our kidneys stopped making urine. So it's just like any other injured part of your body. Say, let's say after abdominal surgery, for instance. So people after abdominal surgery or any surgery tend to have ileus, right? Paralytic ileus, meaning the GI tract stops working. Now this is temporary though. This is because of um, our organs, our internal organs aren't used to be exposed to the atmosphere, handled. So they sustained some sort of injury, so they stopped working. So the same exact reason here, same rationale. So if the kidneys were exposed to pre-renal, intrarenal, or post-renal uh, injuring agents, it will stop working for a while. And the clear manifestation of this is they stop doing their job. So they stop making urine. However, there's really no such thing as, if you remember in anatomy and physiology, Dr. Farrington mentioned about obligatory urine output, meaning no matter how um, dehydrated you are, there is a minimum amount of urine that the kidneys must make, okay, regardless of the injury. So there will be, when we say anuria, in fact, the range for anuria is 0 to 100 ml. Anuria doesn't really mean zero urine output. It's still a range, 0 to 100 ml per day. But it's so small because 100 ml is what? Equivalent to a small, yeah, half a container of yogurt. Okay, so it's not worth talking about. So if you ask a patient who's on dialysis if they still pee, they'll say no, but they actually do. But it's so small that it's not worth considering that, oh, you call that peeing? Those few drops that I dribbled. Okay, so here the patient again goes into 400 ml per day. And if you distribute that over the course of a day, that's really equivalent to a few dribbles when they actually go. And along with the other functions of the kidneys, so now they stop eliminating. So that's what we started with earlier. So electrolyte levels rise, specifically potassium. You go into acidosis because as you have accumulation of your waste products, that will decrease your pH. And then we also mentioned that the function of the kidney is also fluid regulation, right? So they go into fluid overload, therefore the blood pressure also rises. So this phase can vary. If we get to the patient sooner, hopefully we didn't expose it longer, because the longer the patient lasts in the oliguric phase, then as stated here, the longer the oliguric phase lasts, the poorer the prognosis. They will be unable to progress to the next stage, because the next stage is near recovery. The diuretic phase is now a running toward recovery, meaning if the patient receives interventions here, let's say we gave them fluids or whatever the cause is. If it's pre-renal, we improve blood flow to the kidney by, let's say, the who lost blood again? Trinessa. Okay, Trinessa received IV fluids and blood transfusions, okay, but from her blood loss. And or the patient with the kidney stones, we removed the kidney stone, okay, so urine was able to resume flowing. The patient who had the pyelonephritis, the infection of the kidney, was given antibiotics, so we treated it. Okay, so as long as our patient receives treatment to eliminate the pre-renal, the intrarenal, or the post-renal cause, they will progress to the diuretic phase. They will reach this phase. And this is now good because the patient is trying to resume function, but it can't do it normally yet. See, because it's normally oliguric and then you're supposed to return to normal. So not recovered fully yet, because here they're doing it too much. They went from not making urine, not making enough urine, to making too much urine now. But this is a good sign actually. If they reach the diuretic phase, meaning the kidney is trying to recover and resume function. But however, again, it's not perfect yet. They haven't fully recovered because they can't control the amount of fluid that they are releasing. But it's a step toward recovery. So we just continued our interventions here. So we support the patient. We'll discuss the treatment next. So we support the patient during the diuretic phase until they recover. Recovery, though, is a longer period. This can last from months to a year because it's not easy to recover from a um, acute kidney injury. Okay, so this will be months to a few years of recovery. Any questions so far on the phases? All right, let's go to manifestations. So the manifestations really depends on the phase. Okay, so if you look at the patient during the oliguric phase, what are the manifestations again? Which will help us identify that the patient is still in the oliguric phase. Miss Vivian. So let's enumerate. So let's say I put this on a test question and I say the nurse recognizes that the patient in AKI is still in the oliguric phase. By which of the following findings? Select all that apply. Hello? Are you still with me, guys?
Yes, we are there.
Yes.
Okay, all
Yeah.
right. I thought I lost you and I'm talking to...
Okay, I'll help her out. The patient urine output will be below 400. The
All right,
creatine and bond will be increased,
very good.
and there will be some electrolyte imbalances.
Okay, particularly again, I said it's potassium, right?
Yes.
Okay, potassium will be high or low?
Excuse me.
What do you think the potassium level will be? Will it be high or low?
The potassium is going to be you're peeing, so you're letting go a lot of potassium. So therefore, it's going to be, you might go for hyperkalemia.
Hypo or hyper?
Hyper.
Yes.
I didn't hear you clearly. Low or high?
High.
Okay, very
Yeah.
good. So you'll have potassium retention because the major elimination of potassium is done by the kidneys. The kidneys
Yeah.
are responsible, like I mentioned, I think I mentioned last week, 80% of your potassium excretion is done by the kidneys.
Yeah.
The other 20% is divided between the GI tract and the skin. So these are your manifestations. Now let's go if they survive the oliguric phase and then enter the diuretic phase, which again we don't know exactly when. It depends on how soon did the patient receive intervention, or in the same way, it also depends on how long they sustain the oliguric phase. Okay, that makes as stated again here. So the longer they stay in that phase, the poorer the prognosis. So they tend not to enter the diuretic phase. So what will happen is they'll be here forever because the CKD, the chronic kidney disease, remains here forever. They never recover. They stay oliguric for the rest of their life until they get a kidney transplant or until they resume, begin hemodialysis or peritoneal dialysis. So let's look at diuretic phase now. So this indicates again that the patient is now starting to recover, but hasn't fully recovered yet. So here, the cause of the AKI has been corrected. We eliminated the pre-renal, intra, or post-renal cause that led to the oliguric phase in the first place. So now the patient enters the diuretic phase. The major manifestation, of course, is by the term itself, diuretic. So the patient diuresis. Look at this amount. So normally we pee about 1500 ml. So now we reach up to 5 liters a day. That's a lot of urine. However, the danger here is Without again looking at the interventions, what do you think will we do for the patient who is in the oliguric phase, Miss Lou? So if your patient is not able to make urine, isn't able to regulate blood pressure, isn't able to eliminate water, isn't able to eliminate waste products, isn't able to regulate electrolytes, what will be the patient's orders?
Hello. Oh, diuretics.
Very good. See, you guys know this because we haven't even looked at the interventions. You have the basic concept. Okay, what else? Doesn't have to be Miss Lou. Thank you, Miss Lou. But anybody. So we can give diuretics to push this patient to the next phase. What else besides diuretics? What do we do about the fluids?
You restrict.
You
Oh,
can
you
give them
restrict
more
them?
IV
Very good.
fluids.
Fluid restriction. How much fluid restriction exactly? Because it's easy to say fluid restriction, but how do we determine? Because what if the patient asks you, okay, fluid restriction, well, how much can I take? How do you answer?
Less than 1,000.
Okay, the basis for the fluid restriction will be how much can
Based
they
on
handle? How, or particularly, how much can their kidneys handle? So if their urine output was only 400, let's say yesterday, how much are they allowed to drink today?
Less than 400.
Well, their kidneys were, let's say this is the next day. So their kidneys were able to make 400 ml of urine yesterday.
Mm-hmm.
So that's all that their kidneys were capable of doing. So how much water do you allow them today for the next 24 hours?
Additional 600.
5 or
Okay,
600.
at least 400, right? Because remember, we talked about it last week. Is the urine the only way we lose water?
Oh, yeah,
Yeah.
no. Lose it through talking, breathing,
Okay, so
No.
sweating.
right. So we will have to estimate that. So most doctors estimate it at around 600 ml of insensible fluid loss. So 600 plus 400. So the patient may get about 1,000. They may increase the insensible fluid loss allotment in the summer. So let's say it's hot, so the doctor may give more fluids because they consider perspiration, and then evaporation, natural evaporation of water from the body during the summer. So they may increase it, okay, depending on the season. So we did diuretics, fluid restriction. What next? You know the problems here. So I'm telling you, it's easy to answer the exam because you know what's going on with the patient with each phase, so you know what to do.
Sodium and potassium restriction.
All right, very good. So the diet will have to be restricted here. So we know that BUN creatinine comes from what? What are BUN creatinine? These are nitrogenous waste, right?
Yeah,
Where did nitrogenous waste come from?
the kidneys.
The kidneys.
Urine.
Protein. Breakdown of
Protein.
protein.
Well, the kidneys eliminated. So it came from protein. So therefore, if every time you consume protein, you are making BUN and creatinine,
Increase.
do we allow this patient
Oh,
to
you
eat
will
a
reduce the
19-ounce
protein.
steak?
No.
No.
No, we have to control the amount of protein this
Protein.
patient eats. So the doctor will calculate that based on the BUN creatinine levels. So they usually go with either 60 grams or 70 grams protein. What about the electrolytes, sodium and potassium? Do we regulate the intake also?
Yes,
Yeah,
we have
because
to.
where
Okay, so
sodium
the
goes, where
patient
what
may
goes.
receive 2-gram potassium or 7-gram no, 2-gram sodium, and then maybe 3-gram potassium. Depends on the level. And of course, we have the fluid restriction already. So that's the diet. And what about medications? Because what's this patient's blood pressure?
Usually high.
Very good. So how do we say too bad?
No, we have to try to control the blood pressure with
Okay.
some fluids.
But
give you-
diuretics will change that too, right?
Yes, but the blood pressure will be still high though. The diuretic won't be enough. So this patient may receive, what medications do we use for blood pressure?
Oh,
Like the pills,
ACE
inhibitors.
the
All right.
better
Okay, very good. So we give the patient ACE inhibitors or ARBs. Okay, very good. So you know the interventions. So when we get to the interventions later, you'll go faster. All right. So we're doing this treatment, right? How do we know when to stop that treatment? Because with that treatment, the fluid restriction, the blood pressure medication, the diet restrictions, fluid restriction, is that indefinite?
No.
You have to keep
Do we
taking the
know?
labs. You have to take the labs.
All right, so this is now the crucial part, because what happens, look at this, when this patient recovers and goes into the diuretic phase, look at this. The patient loses this much water in a day in the urine. So can that lead to dehydration and electrolyte imbalances?
Yes.
And what were you doing in the oliguric phase with the fluids and the electrolytes?
You was retaining it at first.
No. What were you doing? Your interventions. What were your interventions during the oliguric phase?
Oh, you was trying to get them to eliminate more urine.
We were trying
Plus,
to
you were
control the
restricting,
BUN and
right?
creatine level.
Fluid restriction.
Yeah, you were doing fluid restriction. You were restricting electrolytes. You were restricting protein. So therefore, if you're not aware that the patient has left the oliguric phase and now has entered the diuretic phase, but yet you continue the interventions you were doing there, what will happen if they enter the diuretic phase and you missed that opportunity?
They might go into dehydration.
And hyponatremia.
Okay, look at this in the first place. So the patient now suffers dehydration and electrolyte imbalances, right? What was one of the causes that led to the kidney injury in the first place?
Dehydration.
Dehydration was one of them. So now look at this. You started with dehydration, right? You entered the oliguric phase, and then now you're trying to recover, and then you got exposed to dehydration once again. You think you'll go into recovery?
No, you might, if we don't try to improve the diuretic phase, he might go into shock.
You'll go back to the oliguric phase and then stay there forever.
Yes, yeah.
All right, so that's the consequence. So this is the reason why AKI patients are in the ICU, because they want nurses to watch these patients carefully, 1-to-1 or at least 1-to-2, because they can't afford putting this patient who is oliguric in a regular med-surg floor wherein a nurse has to watch 6, 7, or 8 other patients along with this patient, right? So this is crucial. When the patient enters the diuretic phase, you must identify this phase. That way you can call the doctor, because now do we need to continue the fluid restriction, the blood pressure medications, the sodium and electrolyte imbalances, the diuretic therapy. Do we need to continue that once the patient enters the diuretic phase? Hello?
Probably not.
No, not probably. Definitely no. We can't continue because now the patient is losing a lot of water. So let's look at it one by one. Is the diuretic therapy still applicable?
No.
Definitely not, because they're already diuresing. Is the fluid restriction still applicable?
No.
Is the electrolyte restriction still applicable?
No.
No, we need to stop those now. And instead, what will we do during the diuretic phase?
Fluids.
Okay, now we start replacing the fluids that they are now losing through the urine. Okay, and then we now replace the electrolytes that they're also losing through the urine. All right. So we have to change but the crucial part here is if you catch this at the right time, because if you don't, the patient suffers dehydration and then they go back here because you have now another event that led to another pre-renal state. And now the patient re-enters the oliguric phase, and then this time though there's no chance because they had this one chance to recover right here, and then you missed it. They go back here, and unfortunately there's no second chance. They enter the CKD, which is now the next problem. So recovery, again, this will we don't talk about that because that takes several months. So they just continue, going back to normal, and then we just monitor their kidney function throughout that time. So as far as clinical manifestation, it really depends on the phase. So I can't really say, oh, this is what happens. This is what you see. It depends. When is it going to be seen? So that's why here in your table 62-3, it tells you during the oliguric phase, this is what the urine volume looks like. Okay, and then here, fluid overload only during the oliguric phase. And then they have here decrease calcium, phosphorus, and they tell you when, etc. But anemia, like I said, doesn't really occur in acute kidney injury because although it's listed here, I don't know why. This doesn't last very long. So it's only, what did it say here? 14 days. Okay, so the kidney function stops for about 2 weeks. So there's really not enough time for anemia to significantly develop. It's more a manifestation of CKD. So here are the management that you already told me. Okay, so no need to do it again because you already told me about the interventions. Here, medications, you gave me diuretics, and then of course we stop the patient from being, if possible, okay, we avoid nephrotoxic agents. That way we do not exacerbate the condition. Here we manage the individual problems, supportive therapy. Nutrition, you already told me that we're going to be restricting the diet. Okay, here, definitely put sodium, potassium. It has to be so many grams only. The doctor has to be specific. Here we have managed hypertension that results, or potentially if the patient goes into heart failure during the oliguric phase, which is possible because they are in fluid overload. If needed, dialysis was mentioned here in the oliguric phase. Right here, right here. So the patient may need short-term dialysis. Okay, we say short-term because we're not expecting this patient to definitely stay here. But like I already discussed, this is possible that they may, if you miss this phase here, meaning you did not change the orders, you did not call the doctor for a change of orders, and then they return here, that dialysis will become permanent. We'll discuss dialysis separately toward the end of the chapter. So of all the problems there, the hyperkalemia, the hypertension, the heart failure that could develop during the oliguric phase especially, is the most life-threatening acute complication is, of course, the hyperkalemia, because this can lead to cardiac arrest. How you identify it, hypokalemia, this is a very unique feature. We haven't done module 8 yet, but on an EKG, this is the only time that you have a really tall and peak T wave. T wave is the represents the electrical activity of the heart during relaxation. It should only be this high, about half the voltage happening during contraction. So if this is how many? 1, 2, 3, no, 5, 2. So this is 2 millimeters here. This is about 2.1 millimeters high. This is now over 2 millimeters. Okay, it's even higher than your R wave. This is the peak of your electrical activity at the peak of your ventricular contraction. This thing here is supposed to be down here, right? Or only one big block high. The T wave should only stop here. Look at this, because you don't have enough potassium. I mean, you have too much potassium, sorry. Okay, so that will cause a peak T wave, and it's easy to identify. You see that? Always check electrolyte levels, because there's really, I don't remember any other cause that will lead to a tall, really tall and peak T wave. So management, we already discussed this last week, correct?
Yeah.
All right, so we talked about insulin with glucose, but remember it should be together, insulin, IV insulin with glucose. And we have albuterol. We said this was 4 times the dose, right? Albuterol, it won't be 2.5, it will be about 10 milligrams. So you'll administer 4 times the dose of albuterol, and we give calcium bicarbonate, which has the same effect as insulin with glucose. Then we have the SPS, which is sodium polystyrene sulfonate, KXlate. But how long does this thing work again? Why is it not a priority here? Why is it number, what is this? One, two, what is it, the third option?
Because it's not KXlate can potentiate kidney.
Actually, no, it doesn't. It eliminates potassium, but how long
Potassium.
does it take
It
though?
takes
How long does it
takes
take?
a long time before it
Time.
becomes
Hey, it takes
effective.
2
Yeah,
hours.
it's
Hours,
efficient.
yeah.
Work. Okay, so it's not very effective in elimination, but it's the most it's a, yeah, between KXlate and diuretics, it's really reliable in eliminating potassium. The only problem is it takes so damn long. It takes 2 up to 4 hours sometimes before the patient has a bowel movement. So the fastest way again is to shift the potassium. So either the calcium chloride or calcium gluconate, again the same effect as the insulin with glucose, and then until this guy here works. But all will be given. This one first, either or, these two, and then followed by this one. Because remember, these two here, or even this one, do not eliminate potassium. Okay, it's only, look at the verbs they use. This only will stabilize. This one will cellular uptake, meaning you're just putting the potassium inside the cell and out of the bloodstream. This one, these guys here are the only ones that really eliminate potassium. But for in the case of KXlate, takes too long. In the case of diuretics, they also eliminate sodium and water, so it's not very selective. Dialysis, although it says emergent, I mean, it still takes several hours because you have to call the doctor. He has to set up the sterile field. He has to put in a temporary catheter. And then you have to go call the dialysis nurse. And then they have to come in and set up. So all in all, that could take 4 or 6 hours to set up hemodialysis. Okay, so this is a summary. But again, be careful about the phases because the signs and symptoms differs between diuretic and the oliguric phases.
But how exactly do you differentiate in terms of the lab work?
Okay, the lab work, you tend to have higher levels of your potassium during the oliguric phase because your kidneys can't eliminate it because you have oliguria. So when we go to the diuretic phase, it will start to drop because now the patient's kidneys are now eliminating so much water, and along with that will also come your potassium. But we can't really tell exactly how much potassium is eliminated, but it will be definitely lower than it was during the oliguric phase. So oliguric is the patient in fluid deficit or fluid overload?
With
Deficit.
Overload.
No, they're oliguric. They're not making urine.
Yeah, they overload.
They're in
Fluid overload.
overload.
Okay. And then when we enter the diuretic phase, they are now in
Deficit.
fluid deficit.
Deficit.
That's why we
Deficit.
changed. Remember, we changed the orders when they switch phases.
So
In
you
fact,
basically look at the trend of the potassium on the lab.
exactly right.
Okay.
As far as electrolyte goes, there's no other way. You have to look at it. But we definitely, one thing's for sure, it's very high during the oliguric phase because all kidney function ceases to exist during the oliguric phase. During the diuretic phase, some of it is restored. In fact, they're losing so much water, but not fully yet because they haven't fully recovered. So you continue the blood pressure. One thing is constant. The blood pressure control remains during the oliguric and the diuretic phase. By how much will slightly differ because remember you're already losing water in the diuretic phase, so you're no longer in fluid overload, so your blood pressure might start to drop. Any questions? And here is a summary and then nursing care. So the important thing here is the most crucial part is watching that urine output because do we know when the patient goes into the diuretic phase? Is there a set period like Wednesday they'll be good? Can we predict that?
But Professor, although we wouldn't really know, but wouldn't we be able to tell by once we see them start urinating more often?
Yeah, that's what I'm trying to say. Can we predict though?
Oh,
When
we can't I don't think we could predict it, but we'll be able to
Okay, very good.
tell.
That's why these patients will be in ICU. They require close monitoring. All
So
right.
I guess my question is when the urine output increase, how do you know whether it's the effect of the diuretics or the patients entering the diuretic phase?
No, that's it. That's it, Yan. Because just because we gave, I'm sorry, I forgot to mention that. Just because we gave diuretics during the oliguric phase doesn't mean it will necessarily work.
Okay,
But once
got
it
it.
starts working, though, once you have diuresis, yes, they've now entered the diuretic phase. But very good question. Because until the diuresis occurs, you're still in the oliguric phase. And again, I'd like to repeat, just because you're giving diuretics doesn't mean the kidneys will necessarily respond. They may not. They may stay in the oliguric phase, but at least when you continually give the diuretics, you're trying to enhance their progress toward the diuretic phase. You're trying to force the kidneys, go, start making urine already. All right? All right, let's take a break. We'll finish up with chronic kidney disease.